Hi, hello. Hi, my name is Joe Saramelli. It's my pleasure to introduce Dr. Nancy Byatt today. Dr. Byatt is an associate professor of psychiatry and obstetrics and gynecology at the University of Massachusetts Medical School. She's a psychosomatic medicine psychiatrist with expertise in perinatal mental health. Dr. Byatt is the founder and medical director of the Massachusetts Child Psychiatry Access Project for Moms, abbreviated the Mcpatcher for Moms, which provides mental health consultation and care coordination for clinicians serving women during pregnancy and postpartum. Notably, actually, the Mcpatcher for Moms program received the 2017 Gold Award for Psychiatric Services from the American Psychiatric Association. Dr. Byatt's research interest focuses on developing innovative ways to improve implementation and adoption of evidence-based practices, evidence-based depression treatment for pregnant and postpartum women. And one point about Nancy's research work is how quickly her findings have actually impacted the care of women, which I think is really notable. She's really moved quickly from research findings to actually changing treatment and care for a lot of patients. And we were talking yesterday at the perinatal psychiatry pathway meeting about how Nancy's day-to-day work actually spans clinical research, implementation, and policy-related work, sometimes all in the same day. So one other point, Dr. Byatt is here at UW this week on a visiting professorship supported by the Academy of Psychosomatic Medicine. This is a major accomplishment for Nancy. It's a national award, and Dr. Byatt was selected from a pool of applicants to visit us here at UW with the goal of strengthening our clinical and research programs and education in perinatal psychiatry. So one other point, I've known Nancy since 2013 when Wayne Caton actually introduced us at an APM meeting. And since then, I've heard Nancy present a bunch of times at the APM, and I've enjoyed it a lot and learned a lot from Nancy. So I'm really glad she's here today to present. So Dr. Byatt.
Thanks, Joe. It's really an honor to be here and to have this award, particularly because UW is sort of where, or UW, you guys call it, not UW. It's where, collaborative care was born, where Wayne's from. So it feels like it would be an honor regardless, but it's a special honor to be here just because it's UW. So I'm very happy to be here, and I've really been enjoying my 2 days. So what I'm going to talk about today is really tell the story of what kind of came to be with the original research and how that's then impacted some policies and impacted care in Massachusetts and potentially the rest of the country as well. So the first objective is I'm going to describe the program Mcpatcher for Moms and what that is. And the Mcpatcher for Moms stands for the Massachusetts Child Psychiatry Access Project for Moms. And I'll talk a bit more about that. The second is I'm going to describe to you, for you to understand the research we're doing. And I'm going to talk about this program called PRISM, which is Program in Support of Moms, which is really an intensive version of Mcpatcher for Moms. The third is to describe how we've been revising that based on iterative feedback we've been getting from providers and patients. And then the fourth objective is for you to understand how throughout all this, there's been all this kind of policy work happening and a lot of things happening at the state level and now also at the national level in regard to perinatal depression and how that has been very synergistic with the research. And I'm going to kind of weave that thread in throughout. So perinatal depression is very common. It's one of the most common complications of pregnancy. It occurs in 1 in 7 women. So I'm sure all of you in this room have known someone who've experienced this. It's really a very common illness. And it's very well established. It has an impact on mom, on baby, and on the family. So in women who are depressed in pregnancy or anxious as well, it's been associated with poor healthcare use, increased use of substances. And in the postpartum period, it's associated with decreased attachment or bonding with the baby, and also with poor birth outcomes, including low birth weight and preterm delivery. And then if moms have maternal depression, it's associated with their children having increased risk of cognitive delays or behavioral problems. So it's really well established that this is very bad for mom and the whole family. So we know it's common, we know it's bad, and unfortunately, it's underdiagnosed and undertreated. So right now, screening is being encouraged to increase the detection and treatment of depression. So in the past few years, American College of OBGYN, which is the acronym's ACOG, they have come out with screening recommendations. CMS recently came out with screening recommendations. And can you see that? That little, hold on. Annotation is disabled. Okay. And also ACOG and a bunch of organizations just formed to have this Council of Patient on Women's Safety. And they're also recommending this. And actually also American Academy of Pediatrics is now recommending this, and also CMS. So a lot of organizations are really realizing we got to address this. It's a major public health issue. No, that's not going to use this. It's not moving forward for some reason. Oh, can you not hear me? Yeah, I can, yeah. So, and the reason people are recommending this is because the perinatal time period is really ideal for the detection or treatment of depression. Women are seeing obstetricians during this time period, often, unless they have a chronic medical problem, more than they would at any other time during their childbearing years. They're seeing once a month in pregnancy, towards the end once a week, and in the postpartum period. And really every time they see one of those providers is an opportunity to engage women in treatment, to talk to them about this, and to screen them. And obstetric settings and OBGYN providers really have a pivotal role in this process because they're at the front line seeing these women. And also most depression, as you well know at UW, is treated by primary care. And ideally, but that historically, that hasn't necessarily been the case in OB settings. They didn't necessarily see that as their role. But the really thinking is that ideally, depression should be treated during pregnancy as part of care, just how diabetes is, because it's actually twice as common as diabetes in pregnancy. So the thinking here really is that if obstetrical care can be transformed to include depression, that could provide a solution. Because right now, women are not able to access care because there isn't anyone there to treat them. So what we did was, seeing this was a problem, because in general, if a woman is screened positive for depression, less than a quarter of women are going to get to an initial appointment. And so that's why the OB setting is really a place where if you can build their capacity to address this, you can leverage psychiatrists as limited resource and have women treated in that setting, which they actually prefer. So with this idea in mind, this is going back several years now, our team wanted to understand how can we actually do this in OBGYN settings? Because at the time, it really wasn't thought of as, there was actually some work being done here. Jennifer Melville was doing a study at UW. That was going on, but it was really pretty early phases in that. And OBs were not necessarily seeing this as part of their treatment purview because a lot of it was because they didn't know what to do. They didn't want to tell a patient, well, you're depressed. I don't know what to do. Good luck, which is kind of how it might have gone at that time, which we all know is not a good thing. So what we did was we thought, let's try to understand how we can do this. And we did focus groups with both OBGYNs and also staff working in OBGYN clinics, social workers, or perinatal psychiatrists, and also women. And we wanted to understand how can we address depression in that setting? What do the OBs need? How would they like it addressed? And what are the barriers and facilitators? And also, how would women like it addressed in that setting? And the goal was that then inform interventions to be able to develop this. And we really wanted to get their feedback because we didn't want to sit and guess at what the OBs wanted. We wanted to make sure we were delivering something that was actually going to be palatable to them. So this is sort of what we came up with after doing this work. So what we found was that, patients reported people aren't screening us. They were very afraid. They felt very stigmatized. They didn't have, even if they did tell their provider, it didn't feel like it felt pretty futile because they still didn't have access to care. Providers said, we want to address this. We think it's important, but we don't have any training. We're not comfortable and we don't know what to say. And one of the quotes, one of the OBs was, we just ask the question if they're depressed and we hope they say nothing because, we have no idea what to say if they actually answer positive. We just hope that we're like, are you suicidal? Are you homicidal? We hope they say no, because if they say yes, we don't know what to do. That was one of the quotes in one of our focus groups. And the systems were integrated. Psychiatrists actually aren't comfortable treating these patients either. So there was no one even to refer them to in the community. The care wasn't integrated and screening really wasn't routine. So you had this situation where women were not disclosing symptoms or seeking care. You had unprepared providers with limited resources, underutilization of treatment, and poor outcomes. So in Massachusetts, we have this program. This is the KID program called, and actually you now have it at UW. Bob Hill is directing that here. And it's called it's called McPAP, which stands for the Massachusetts Child Psychiatry Access Project. And that was a program that was developed, piloted at UMass in 2005. And the reason this was developed was because there was pediatricians at the front line seeing kids, and kids didn't have access to care, and the pediatricians didn't know what to do. And it was a really big crisis because these kids have mental health needs. There was no one there to treat them. So we piloted a program at UMass where if a pediatrician was in the office seeing a kid and the kid presented with mental health concerns, they could call and speak with a psychiatrist within a half an hour, who would call back. The goal was within a half an hour to answer their questions and hold their hand and help them treat the patient. They also could access care coordination to be able to help link the child with a therapist in the community. They also did face-to-face consults when needed, a one-time face-to-face consult to again build the capacity of these pediatricians. And this program has been really successful. It's been funded by the state in Massachusetts now for 10 years, and it's now in 32 other states in the country. Can people hear me? I just want to check on okay, good. So we saw this program and we thought, well, it's kind of a similar issue with OBs because they don't know what to do. The women are seeing them. They're not trained. There's no one available. Could we perhaps translate that program for depression? So that led us to have this idea of McPAP for moms. And we had this idea, and so what we envisioned McPAP for moms would include would be similar to the child program, so obstetric provider and staff training. We also had this idea to develop a toolkit that they could then use with screening algorithms and telling them at what points you needed to screen and what do you do with a positive screen. The second component that we were envisioning in this McPAP for Moms program was having some procedures and some office prompts and also some environment changes. So depression is really just a routine part of obstetric care, like posters in the waiting room and the initial OB visit when they talk about listeria and all these things that are really not that common. They're talking about depression too, because it's way more likely the baby's going to get the mom, that's going to impact the family than some of these other things that are much less common that get a lot of focus. And then the third piece was this immediate psychiatric guidance via telephone consultation. So very similar to the McPAP program, our vision had been to be able to provide consultation to providers in order to help them manage the patient, and then also face-to-face consultation. And the thinking was that this could improve access to an engagement treatment and then, ultimately improve depression outcomes. So this led to, at the time I was doing this led to with this idea in mind, I applied for a K Award, a grant, a career development award that buys out my time to do research. And I got that funded. And this research, the goal was to pilot a program like this. One was to develop it with iterative feedback from providers. And the other piece was to then pilot test this. And we were going to have 2 clinics that had access to McPAP for Moms and 2 clinics that had usual care, such as screening and referral. So what we did was to develop this intervention. Again, we knew that OBs are different than pediatricians. We know that they're even a lot different than a lot of other, sort of integrated care models because they're surgeons and we're going to have to adapt this for them. So we really, on this theme of really wanting to get iterative feedback from them, we established a working group as part of this grant. And we met with a social worker, we met with a perinatal psychiatrist, residents will be attending, and other nurses and support staff working in the clinic. And we basically sat down and developed each of these intervention components and got feedback from them. So we presented to them, they'd give us feedback, and then we'd revise it. We did this over an iterative process for about 6 months. And then we beta tested the intervention in one practice. We had them screen. We had, I actually did the consultation. I was available to provide consultation over the phone as needed. And then we revised it again based on the beta testing. And that allowed us, at the end of this period, we had this toolkit. We had a training program that we developed with their iterative feedback, and then also fidelity measures to do a pilot study. So we were sort of on our way to beginning to do a pilot test of this. And what it also suggests, and when we did this beta testing, what people really said was that we did focus groups with the people who were doing the providers doing the beta testing, and they really felt like this was really helpful because before this they said, we were basically pushing this under the rug. We didn't know what to do. And now we have a lifeline and we can call, and I'm much more likely to try to treat a patient if I can call them and I can ask someone for help. And it felt like now it didn't feel so ominous to take on this new task. The other thing they really liked was that we'd had this iterative process. So we were tailoring each of the components really to their practice, because we'd say, we want to do this. They'd say, well, that won't work in our practice because of this. So they really liked that everyone in the practice was engaged in that process, the nurses, everyone involved, because I think the nurses really felt like a lot of times some change happened, they were told to do it without really being engaged in that process. And then the real-time consultation. We also got some feedback for things that could be improved. So they really felt we were having a little difficulty engaging the women. So for example, a woman would fill out the screen and then by the time they filled it out, it would work out that the provider got it after the patient had left and things like that. There was some definitely tweaking, or people just wouldn't fill it out because they just didn't see the value of it, or they weren't interested in care once they did screen positive. So we definitely it was very clear we had some work to do with engaging the patients and also making the screen done in a way that was more holistic and less stigmatizing. So in the meantime, we had just done this beta testing. We'd had this sort of beta version of this toolkit and this intervention. And in the meantime, just sort of when we were finishing this, Massachusetts passed legislation to have this program be statewide. And the way that happened was, this is a picture of Rep Story, who was really the advocate of who made that happen. So at Confluence, you might be wondering, well, how did that happen? I wondered it myself. But so what happened was a bunch of events really happened to lead McPat for Moms to be a statewide program. So in 2010, Massachusetts had passed an act, a Postpartum Depression Act, and that formed a commission. And that commission was charged with coming up with some sort of statewide initiative or program to address depression. And when they came up with that, there was a lot of controversy around this, actually, because they wanted to mandate screening, and people pushed back and said, well, if we're going to mandate screening, what are we going to do? We don't want to have this, you're depressed, good luck, but when actually mandate people to do that. So what they did was they had a lot of conversations about this, and as they were discussing this, I had been giving a presentation, and the director of the Postpartum Commission happened to be at this presentation. I had gone to the commission and given a presentation and presented what at the time was my proposal for a K award to this. I presented actually that conceptual model that I had in that slide with the bubbles. And I said, this is the program. I think this could potentially be a solution. We're hoping to get funding for this. They said, that's a great idea. That was that. And then the idea got a life of its own. And then in November of 2003, right after this, we had just had this beta testing done. The program actually got funded because a work group started, which I was involved in, and they were able to advocate for this. Part of it was because we had the existing McPat program for kids, and they could sort of layer it onto that. So now we had, and then in 2014, we had 8 months to launch this program. In 2014, we launched the program. So I'm going to tell you a little bit about McPat for Moms, about the statewide program. Then I'll come back again to the research, because these two things have sort of always been happening in parallel. So we got the funding. That was very exciting. Our little pilot became like a statewide program, which was cool. And we had, we were able to launch this program, and it's been really a wonderful experience, very fulfilling, and really it's been very successful. So the McPat for Moms program is similar to what I was describing before, although a little different than what we had piloted, because since it was the whole state, we had to take out some of the pieces that were practice level, such as the environmental changes and the office prompts and things like that. So what ultimately happened with the McPat for Moms program is we have 3 core components. The first is education. So we go out to practices, we do a one-time, 1-hour training and train practices in how to manage depression. The other thing that we do is we do ground rounds of birthing hospitals. At this point, we've done most of them in the state. The third piece is the consultation, which I described. So we do if an OB is screening a patient in the office and they have a question, they can speak with a perinatal psychiatrist, and we'll hold their hand and help them answer the question. And then and we also do face-to-face, one-time face-to-face consults. And then the third component is care coordination. So if a provider calls and they have a question, we may provide some consultation around, for example, medication management. Often we also talk about therapy and psychosocial treatments, and it gets established that they need that. And then we can refer them to our care coordinator, who can actually call the patient, follow up with them, and help link them with therapy in the community. So that was an addition that we didn't have in that pilot because it was a grant. We didn't have the resources to be able to do that. And then the other piece we had was and then we also have support groups available that we can refer patients to as well. So I'm just giving an example if somebody calls. So if somebody calls the line, we have a 1-855 number. It covers the whole state. So providers can call from throughout the state. If they call, they're going to reach a care coordinator. That's who answers the phone. And then they page the perinatal psychiatrist. We're available. This program is open 9 to 5, Monday through Friday. And they would page us. We would have a conversation. And it may be, to give you an example, I talked to an OB recently who'd had a patient and she wasn't sure how to manage this patient because the patient was depressed and she had never prescribed an antidepressant before. And she said, I'm willing to do this, but I just feel really uncomfortable. Can you see the patient? So in that case, sometimes it's managed because they do feel comfortable. You have a quick phone call. Other times we say, if you need a face-to-face, we then link back to our care coordinator and she'll either refer the patient for therapy if that's indicated. She can set up a face-to-face if that's indicated, or sometimes it just ends after the phone call. We provide some consultation over the phone. Or sometimes it's a combination of all three. And I want to add that we take calls from, I'm talking a lot about obstetric settings right now, but in our program, we actually take calls from any provider working with a pregnant or postpartum woman. So psychiatrist, family practitioners doing OB. We take calls from pediatrician at well child visits because ideally they're screening patients as well. And with the psychiatrist, because psychiatrists often aren't comfortable, so we really need to be building their capacity to treat the patients that really need a psychiatrist. So we take calls from them as well. And so a little bit more information about the program. So we also have a website. On our website, we have our provider toolkit is on there. And we have resources for mothers and families. We have a support group. Women can actually go in here and put in their zip code and search for support groups throughout the state. And that's nice because it's something women can do themselves in case because sometimes women, the provider doesn't want to call or they want to just give the patient a resource. So at least that's something that the patient can actually go in and do herself. So a little bit of data about our program so far. So we opened in July of 2014. So we opened a little more than 2.5 years. And in that time, we're just about at 2,500 patients now because this data is a month old. So I believe we're at like 245 or 2,450 around that. And we've enrolled about a little over 65% of the practices in the state. So you can see the blue line is the number of unique patients that we've served. And the red bars are the practices. So as we enroll practices, the number of patients we're consulting with is going up, accordingly. And I'll go to the next slide. So as long as a practice is enrolled, so we've enrolled about 65%. If you look at that in the portion of deliveries, we've tended to enroll a lot of practices with the bigger number of deliveries. So it turns out to be about 80% of the deliveries in the state that we cover with the practices we've enrolled. We've done about 134 trainings. So we've trained a lot, and these are practice level trainings. We've done a lot of trainings for providers, served, this number's a little higher, more like 2,400 now. And so of these consults that we do, the majority of them, we do have a doc-to-doc encounter, which is this telephone consultation. And less than 10% of our telephone encounters are face-to-face evals. And that's good because we're able to see people typically within a week. So provider calls and they want the patient seen and they need it. I don't think we've ever had more than a 2-week wait for a patient, but usually we can see them sometimes the next day. So that the providers really love that because it's really quick and that is sort of unheard of. At least, especially to see a perinatal psychiatrist within a week. Forget about a regular psychiatrist. And as you can see, we do a lot of care coordination as well. And some of our calls, they call for care coordination. They don't have a doc-to-doc encounter or a provider-to-provider encounter. And the majority of our calls come from midwives. So about 62% of our calls come from OBGYN and midwives. Those are target primary provider population because those are the providers seeing patients the most. And then about 15% come from psychiatrists. And then we also get calls from pediatricians, family practitioners. We had a GI doc call once about a postpartum patient. ERs call us, labor floors, inpatient psychiatry units. So that other 23% is sort of a lot of different kind of providers and settings. And, untreated depression is really expensive. So one of the beautiful things about this model is it's scalable because it's much less expensive than a lot of other models for delivering this kind of care. So this one study here, they found that untreated depression was $22K per year per woman for untreated depression. That equals out to be for the whole state of Massachusetts, if you consider that there's the deliveries in Massachusetts, that's $192 million per year in Massachusetts. If you figure that we have 72,000 deliveries and 50% of them are probably going to be depressed, that's $190 million a year in costs for untreated perinatal depression. Our program costs $11 per woman per year. A little more, sorry, round up 12. So a little over $11 per woman per year. And that's 98 cents a month and $850,000 a year. So it's a lot less expensive than not doing this if you consider sort of the societal costs. So, and we do this, we have one FTE of a psychiatrist. We just went up to a little more than that but that's to do, we're focused on substance use. We provide our clinical care with one FTE of a psychiatrist and 2.3 FTEs of a care coordinator. So it's very lean, and we provide a lot of care to people with a very lean approach. So getting back to the research piece, this was all wonderful. We have the statewide program. It was super exciting. And then all my mentors were, what's going to happen to your K award? Because your usual care just went out the window. How are you going to have a control group? Because I was really going to have a pretty pure control. I mean, it was going to be a control group. So we sort of thought, well, this was obviously a great opportunity, but then we thought, how are we going to revise this research grant? Because I was still in the very beginning of it, and we hadn't done the pilot study yet. And I had actually proposed to the state when we were developing the strategic plan to have all sorts of ways to do these really sophisticated programs where we'd sort of have a step, like a phased enrollment and compare sites. And they didn't want anything to do with that, because it's very interesting when they didn't want to do research on it. And they needed to get it started because the funding was coming and they needed to get started. And there was really absolutely no interest in like studying it as we were doing it. And that was not what the money is there for. The money is there for, I really had to keep my clinical hat and my research hat on very separately for this, because the money is there to provide the service. They just don't want to put money into doing evaluation. As much as I was like, as a researcher, was hoping for that. So then we thought, well, how can we do this? Because clearly the state was not going to fund doing research to do a really sophisticated, but we needed to, obviously, we wanted to still study this and do this pilot study. And also I was accountable for my K award. And so what we thought about the depression care pathway, which, ideally goes from, detection, you're then assessing patients, you then have treatment, adequate treatment, sustainment of treatment, symptom improvement, and improved outcomes, hopefully for mom, babies, and families as well. And then throughout this whole process, you have treatment engagement. And, Mcpatcher for moms, it's wonderful. It's been successful. It really doesn't get down this whole depression care pathway. It's really focused on detection and assessment and treatment, the initial part. Provider calls us, we do a one-time consult, and then we don't necessarily follow up. We certainly are not making sure the patient gets down that whole pathway. And they have to come to us. We're not in the practice of doing any intensive implementation assistance. We're really call us if you need us. So it's really, statewide based and population based in a large way. So we thought, well, ideally an intervention would go down the whole depression care pathway and really help make sure this all happens. So we can maybe add on to Mcpatcher for moms to have a more intensive intervention that gets down this whole, makes sure patients getting down the whole pathway. So what we did was we thought, well, let's, have a more intensive version of this that builds on Mcpatcher for moms, because now the whole state has it, so we can't not have it. So that led us to develop and conceptualize the program in support of moms, which stands for, the acronym is PRISM. So what PRISM, the differences between PRISM and Mcpatcher for moms, it's more of a practice level intervention versus, statewide. And we work very intensely with practices to help them implement some of these changes. So, because to give an example with Mcpatcher for moms, we go to practice, 1 hour training, and we tell them we recommend that you screen at 3 time points, twice in pregnancy and once postpartum. But sometimes they do that, but they don't always do that. And a lot of practices don't do it after we do a 1 hour training. And with PRISM, what we do is we really want to help them to screen patients, to then treat and follow up with treatment, and then also to be monitoring them and to be engaging the patients as they're doing this, and also engaging the practice. And the way we do this is through providing implementation assistance. So we knew that was missing for Mcpatcher for moms. So what we do in this is we go through, these are the differences. So Mcpatcher for moms we're recommending they screen and refer, and then they have access to our program. And with PRISM, we actually work with them to develop a screening protocol. So we have an algorithm in Mcpatcher for moms for screening protocol, and we tailor that to the practice. We sit down with them and say, what are you doing right now? How can we help you do this better? If they are screening, how can we make sure that all the women are getting screened? And working with them to tailor that screening protocol to their practice and make sure they're actually implementing screening at these 3 time points. And then we do this through this implementation system. It's actually similar to what we did in the beta testing, is that we have this iterative process where we sit down with them, we come up with solutions, and we really, and the more I do this work, it's absolutely with implementation, one size fits none. Because what works for one practice doesn't work for another. So we tailor it very differently. We also enhance the training in the toolkit specific for their practice. And we also work with them to develop office prompts so that when they screen a patient, they can actually make sure they're following up and that they follow up with them after they screen positive. And then they also have access to Mcpatcher for moms. And this is, different because it's more proactive and it's more practice-based. And then what we did to follow patients, so in this pilot study, we had 4 OB/GYN practices, 2 had Mcpatcher for moms, which is enhanced usual care, and then 2 had PRISM. And then we recruited patients that had greater than or equal to an EPDS of 10, which is suggestive of depression. The EPDS goes from 0 to 30, and when people have 10 or above, that's typically suggestive of depression. It becomes a little more specific, or a lot more specific around 13. But that's suggestive of depression when they're greater than or equal to 10. And then we followed them until they were 3 months postpartum. So I'm going to give you the results of this pilot. I'll tell you about the results of this pilot. So what we found, one of the things we wanted to look at was, are we helping the providers? Because the whole way this works is if the providers aren't feeling more comfortable, we're not going to help the patients because it has to be palatable to them. So before we started both Mcpatcher for moms and PRISM, we did surveys with the providers and asked them, are you comfortable in your ability to effectively treat depressed obstetric patients? Before our program in the Mcpatcher for moms group, 0% of them felt comfortable. And at the end of the pilot, we were doing this for about 1.5 years, 33% were comfortable. So many more providers were comfortable treating. In the PRISM group, 9% were comfortable before this, and then 53% at the end of the study. So we were certainly helping providers feel more comfortable, and more so with PRISM. This is a bit of the baseline patient characteristics. I want to point out a few things. So we had 30 patients overall. We had 21 in the PRISM group. And then we had 9 in the Mcpatcher for moms group. And part of why we had 9 in the Mcpatcher for moms group alone is because we didn't do this implementation assistance. And we were relying on them screening to be able to recruit the patients, because we'd go pick up, the RC would go and pick up the screens and then recruit patients that way. And one of the practices never started screening in the second, third trimester because we weren't helping them do it. And so it was very hard to recruit from that practice. This is why we have lower numbers in the Mcpatcher for moms practice. So that's just really the main thing I wanted to point out. And we actually had a very good retention rate. We only had 2 patients who didn't complete, and both of the patients that didn't complete had a perinatal loss. So we looked at depression scores by study and time. So what we found was that in the Mcpatcher for moms group, they entered the study with an EPDS of 15, and by the end had an EPDS of 10. So a decrease in just a little less than 4 points on the EPDS, which I think clinically is quite, if a patient gets better by 3 points, that's clinically significant. And in the PRISM group, they started off with an EPDS about 13.5 and went down to 6. So an even bigger difference on the in EPDS scores. And what we ideally would like to see, I mean, this was not powered to be able to, it was a feasibility study. So we certainly were not expecting to be seeing a difference between these two, a difference of differences. That was not significant, but both of these pre-post comparisons were statistically significant. We then looked at it in a different way. We looked at all the patients entered with depression. So 100% of the patients entered with an EPDS greater than or equal to 10. And then we looked at the end of the study, how many of them still have an EPDS greater than or equal to 10. In Mcpatcher for moms, they all entered depressed, and 44% had an EPDS suggestive of depression after at the follow-up assessment. And in the PRISM group, 100% entered, and then 28% at the follow-up assessment. So again, similar theme where Mcpatcher for moms is helping, but PRISM helps even more, essentially. And then again, with this sort of similar theme, we did a lot of iterative feedback, and we got some qualitative data that led to refinement of PRISM. So what the providers reported when we did this was that Some of the barriers were, again, we still had to be working on this engagement with the patients. You know, we had actually, we did a lot of things to change it. Like, we actually had a cover sheet for the EPDS, and we have them talk to them about it. We developed a lot of protocols for them to do it. There was still some patients that did not want to engage in treatment, or that they worried would say they wanted to but didn't follow up. And it was very clear we needed more proactive patient engagement process as part of this. And then we also had some the providers really reported similar. They, you know, Mcpatcher for Moms was a part of both interventions. They really liked it. One of the quotes from one of the providers said, you know, before these programs, I would just throw this under the rug because I didn't know what to do. And we all threw it under the rug. He said, now we have a lifeline we can call, and I'm treating these patients, and it feels so much better. And I want to thank you for that. So that was very gratifying. And they also reported that they liked the implementation assistance because they wouldn't, the folks that were in the PRISM study said that we would not have just done all this screening. We wouldn't have done it without you guys meeting with us and helping us figure out how to do it. And tailoring it to their practice and being flexible around that. So in summary, the pilot data suggests that both of these do improve depression outcomes. And the difference improvement among the groups is clinically important, not statistically significant. This is between the groups. And clearly we need effectiveness data. So we were able to we're now in year 2 of this grant, we were able to get a grant from the CDC, a UO1, to be able to test the effectiveness of Mcpatcher for Moms versus PRISM. And also to then improve this intervention even more, because we definitely know that there's a lot of things how we can still be addressing depression even better. So that leads us to, we had Mcpatcher for Moms, we have the statewide program, we enhanced that, and then compared Mcpatcher for Moms to PRISM in this pilot group RCT. And then in the CDC UO1, we are doing a much larger trial where we're enhancing PRISM even more and comparing that to Mcpatcher for Moms, which I'm going to talk about what we're doing there. So what we want to do in the CDC study is really to compare perceptions of providers' ability to treat depressed obstetric patients in practices randomized to PRISM as compared to Mcpatcher for Moms alone. And then also look at depression severity in the 2 groups compared. And, you know, the policy implications of this, as we were doing this, and this is the case we made when we wrote the grant, was that regardless of what the outcome is, we're going to have really important information to disseminate. Because if we find that, we thought it was pretty unlikely we're going to find that neither of them work. So but if we do, then we know we have to do something else. But if we find that both groups are equal, that both of them are effective, then we would disseminate and implement the less expensive version. So then all states should have Mcpatcher for Moms, would be the policy implication. And that wouldn't be so bad because maybe all this expensive stuff in PRISM you don't need, and all you need is that. We suspected that wouldn't be the case, and certainly our pilot data was not suggesting that. If we find that Mcpatcher for Moms helps, but PRISM helps even more, which is what our pilot data suggested, the policy implication would be that Mcpatcher for Moms is a great structure. It reaches a lot of patients in a cost-effective way. However, for example, for a vulnerable population, for specific practices, you can have PRISM when you can afford it and have even these more intensive interventions, which is going to help even more. So that would sort of be the implications of that. So I'm going to tell you a little bit about the group RCT. So what we did was, we're now in year 2 of this grant. So we're just about to randomize actually very soon these practices. So first, what we have been doing is refining PRISM and also our large RCT protocol. So for example, we are not relying on the screens to screen patients because we're screening them all over the phone actually, and we're not relying on them screening. Because we really actually want to see if some of these practices aren't going to screen at all, because not all practices in Mcpatcher for Moms screen. So we're actually interested in that. Will they screen without this implementation assistance? So we're not actually, in the pilot, it was screening and referral and Mcpatcher for Moms, and now we've taken out the screening and referral. It's just access to Mcpatcher for Moms. They're not changing anything. We're just going to see how they do. And we're recruiting and following the patients totally outside the clinic setting. So it's more, we're going to get a better sense of what's happening if really they just have access. And then so that's what we're doing. We refine the RCT protocol, and we're doing a run-in phase. So a run-in phase is where we are basically collecting a lot of data from the practices and also about the women, so that then informs the randomization, so we can make sure there's balance among the groups. We're about to finish that run-in phase within the next months and then randomize the practices. Then the next phase of the study, which will start soon, is to randomize 12 OB/GYN clinics. 6 clinics are going to have Mcpatcher for Moms alone, and 6 will have PRISM. And then we randomly select patients from their study. They send us a list of their patients. We randomly select patients from that list and we call them. and we recruit them into the study, and then we follow them until they're 12 months postpartum. Because we really want to know, are they staying better too? The pilot was only 3 months, but this is 12 months because we really want to know. And we're assessing depression severity and also treatment participation. And then phase 3, the goal when they put out the request for proposal for the CDC grant was to inform a national model. The phase 3 of the grant is to, assuming we find it's effective, to disseminate and facilitate national uptake. So I'm going to describe now how we've refined PRISM even more. And so the first piece I'll talk about, we still have these 3 core components: screening, treatment, and monitoring, with the themes of using implementation assistance to help the practices do this, and then also engaging patients throughout. So what we do with screening is we recommend screening at 3 time points: the initial OB visit, 26 to 28 weeks, and 6 weeks postpartum. And that we did in the pilot. What we're adding in this larger RCT is to also screen with the MDQ, because we actually have been very, very concerned about the ability of practices to be able to screen for bipolar disorder, because we think that they're just sort of knee-jerking from assessing a patient or screening a patient to treatment without ruling that out, which is very concerning, because if you can make a patient manic by having undiagnosed bipolar disorder, and even if they don't get manic, they're not going to get better if the treatment's not the correct treatment because they're undiagnosed. So what we're doing is having them screen with the MDQ at the initial OB visit. The other piece we're doing is we're stepping up care as needed. And what we're doing is and we've sort of simplified this in a lot of ways. So education and monitoring at EPDS is less than 10. If the EPDS is greater than 10 and MDQ is negative, then they can manage in the OB setting with help from Mcpatcher for moms. And if the EPDS is greater than 10 and the mood disorder questionnaire MDQ is positive, then they can refer to a psychiatrist, and they can call Mcpatcher for moms for help with that. So, and obviously this is far more complicated. The OB, when we had the slide more complicated, the OBs didn't like it. So that's why it looks so clean. They don't like a lot of words. So this is kind of just a gist of kind of how we're doing this. And we're working with the practice to figure out, what are the protocols for doing this? How can we make sure that if the MDQ is positive, you're following it and you actually are aware, because they do that only one time at the initial visit. As far as the monitoring, we're actually, using some collaborative care approaches here, a lot of which, come from here, that to have a navigator to help ensure women actually get in treatment and stay in treatment, because this was not happening in the pilot. And so we have a navigator that really is a liaison between the patient and the provider. And we're doing this a little differently than how a lot of the traditional collaborative care models do. We are using somebody who's in the practice, because we're trying to make it so it's scalable. So what we're doing is, for example, and we just beta tested this with a practice, and they have an MA, and the MA developed a registry. She would put in every patient who scores positive on the EPDS, enters the registry, and then she calls them at 2 weeks after her positive screen, 4 weeks and 6 weeks, and then as needed after that to make sure that she's following up. Did you get in treatment? Did you stay in treatment? Are you taking your meds? And if there's a med problem, she'll liaise with the provider around that. And she can also liaise with Mcpatcher for moms as needed to help with therapy resources. So we sort of talked a little bit about this. So regardless of what we find, we think there'll be important information to disseminate, because these are, the 3 possible outcomes which I spoke about. And we certainly hope that we're going to find similar results we did in our pilot. So going back to, what's been happening on a policy level throughout all this. So meanwhile, this was happening, and we got the CDC funded. Representative Catherine Clark, who's from Massachusetts, saw we had Mcpatcher for moms. She really liked this. She liked it. It does have a very good reputation, and she was inspired to put forth legislation, which is called Bringing Postpartum Depression Out of the Shadows Act. And it's a bipartisan, bicameral federal legislative bills, and it has, which is HR 3235 and Senate S 2311. And that bill was that started about a couple of years ago, that bill, and it was originally a standalone bill. And the great thing about it is it's bipartisan, and there's not that many bipartisan bills being put forth these days. So she was very smart about the way she did that, because she had a lot of Republican support on this. So that was a standalone bill, and it got wrapped into the 21st Century Cures Act, which just got actually passed in December. So this actually got passed. This bill, as part of the 21st Century Cures Act, got passed into law in just this past December. And what this bill would do, it would appropriate $5 million for not less than 3 states to have similar programs to McPat for Moms. So, which is great, and which was sort of not, a lot of this things happening were beyond what we ever could have imagined, particularly because it happened so quickly. And what happens with this bill would be that, my understanding is that if a bill getting into passed to law and actually getting appropriated is 2 different things. So we'll see what happens, particularly with all the changes going on in DC. But regardless, it's very exciting. So we're really hopeful that, and we're sort of now doing some lobbying and getting involved in sort of the folks who are supporting this to hopefully actually get this money appropriated. So, and the other piece that's sort of happening is that this is really being spreading and viewed as a national model. I mean, this is just like, you guys have a version, I have UW Star in Washington here because you have a version of this. And a lot of states are either starting this, trying to get funding. Really, we've been amazed that we really haven't reached out to people and sort of disseminated this that much, but people are just hearing about it and really just, what I keep hearing from people is that they're really seeing this as sort of Massachusetts having the gold standard of how to do this. So that's very exciting. And so now we're beginning to think about how can we, help other states and provide technical assistance, particularly as these, places get funding for this. Because we've learned a lot and we want to make sure states are doing it in a way that's efficient and successful. And then as I described, that act was signed into law on December as part of the 21st Century Cures Act. And I just have a few pictures here because this is the group, this is the National Mental Health Coalition, or National Coalition of Maternal Mental Health. And this woman in the middle, Jamie Belcito, she's an amazing advocate who's a survivor of postpartum depression and OCD, and really is a very charismatic person. And really the bill got passed, a lot of it's because of her. And it's been amazing throughout this process how, we've been doing the research, but then also having all these relationships. And I think that makes a huge difference because, Jamie's really, I don't think the bill would have passed without her. I mean, she's going down there, banging on these, all the congressmen's doors and just getting this thing passed. And this is the logo for that coalition. So I'm very thankful to them for all the work that they've done. And a lot of people are just doing this, she's all donating all of her time to do this work. So it's been pretty amazing how all this stuff has sort of come together. I hope the money gets appropriated. We'll see, but it's very exciting. So in summary, we have found that, science can positively impact because this all started with a couple of focus groups, and it started with, with science. And I do think that throughout this whole process, we've learned a ton, and I've been directing this program and learning is talking to the providers on the phone, but also then doing research and having funding to learn about it in a way that we wouldn't have without the research. It's really allowed us, I think, both to increase the quality of the program, but also increase the quality of the research and have it be something that's scalable and that hopefully actually impacts more than kind of the 100 patients that you randomize into a study. So it's been very, it's been really nice that we've been able to do that. And this is a thank you for all of the people who've been involved. And I think we have a few minutes for questions. Thank you for listening. Oh, yeah. Yeah, I'll do that, sure. Anybody have any questions? Yeah?
Did you interview the participants themselves to see what they thought of the program?
Yes, we did. So we did that through PRISM. Yeah, we did. And they found what they really liked, the patients really liked Mcpat for Moms for sure. And also when depression was addressed in the OB setting. So kind of both interventions they liked. I'll talk about Mcpat for Moms first. With Mcpat for Moms, they were very thankful of the care coordinator because the care coordinator would follow up with them, and the particular one that they were involved with is very committed, and they liked that there was someone holding their hand and making sure they got into care, and that their experience was that was very, very helpful. And then the other piece that they liked was that they liked that they could talk to their OB provider versus, going down the hall to a psychiatry clinic that's half the time, in another somewhere else. And they're not committing to being a psychiatric patient. And I think that's really huge because patients really like having this addressed in their setting. I was really amazed at how, a lot of us think, it'd be great if they could see a psychiatrist because, we're the experts. At the same time, they don't want to see us a lot of times. And if it's monotherapy with Zoloft, they don't necessarily need to see us. And they much prefer to go to their OB setting. It's less stigmatizing for them. And they like it. And same with when they do a face-to-face eval, we find that. Because it's just a one-time consult. They're not committing to be a patient for the next, decade or what have you. So, and I think the other thing they liked for the PRISM piece where we did this, implementation assistance, was they loved that it was just a part of the obstetric care. A few of the patients said that we went in there and it was like as soon as we became pregnant, they were talking about this and it was just a part of the care. And so when I did get depressed, I knew I could tell her about it because I knew that they wanted to hear about it. We definitely still had some things to improve, which was the engagement and following patients over time. They did report that, like one of the, I think, really aha moments for us was one of the patients said that, we wanted the provider to be more assertive about the treatment because in this case, the patient reported that the provider had said, oh, you're depressed. Like, I recommend, this is your options. Let me know if you're interested or like tell me at the next visit. And if you think about diabetes, you would never say, oh, well, your screen's positive, your blood sugar's high. If you want some, medication for insulin, call me next week and let me know, And you would never do that. You would actually say, you need this treatment, and this is the plan, and we're going to follow up. And it would be very, very, there would be a very, very concrete plan, and they wanted that. So that we're sort of still working on. And as we do this implementation assistance, we're trying to have a very, very clear path of how we can. It really just needs to be like diabetes and put into care just like that, and not seen as like an optional thing.
What percent got medications versus like CBT or both?
Yeah, it's a good question. So a lot of them get both. With Mcpatcher for moms, I'd say we get calls about, I don't have the exact numbers on me right now, but we get calls about most times we talk to a patient, we're also recommending therapy. So I'd say it's about the majority of the patients we're also recommending therapy. So it happens a lot. The piece is making sure that they're staying in the therapy. So yeah, therapy is a huge part of it.
That's exactly what my question was. And
Yep.
One of my concerns about this being scaled up is
Yeah.
the ability for patients to access therapists.
Yeah.
Is that something you noticed already? Or?
Yeah, so in Massachusetts, we don't actually have a problem with them accessing therapists. It's actually, we're able to get people, psychiatry is way harder. So we have a major problem. We worry about that with bipolar disorder, for example. If they screen for that, where are they going to go? So, but with therapy, we're actually able to get them in within usually a couple of weeks. It's really, we rarely have problems getting them linked with a therapist. Sometimes if they're speak a very, a language and they need an interpreter, we can have trouble. But generally, it's actually, we can typically get them in. What we worry about, and Nancy Grote and I were just talking about this morning, is that quality of therapy. And therapy is not something that is a core part, because the mission of Mcpatcher for moms is really to help the medical provider, to help them, be able to provide the treatment. And they're not going to do, B's never going to do the therapy. But what we really worry about is that when we do refer for therapy, we can get them in. We don't know if it's evidence-based psychotherapy. And I suspect most of the time it's probably not. So that's a piece where I do think that's a major hole in the care that really needs to be addressed. And we are, that's something that we're sort of thinking about, because it's tough, because we can get them in, but we just don't know it's evidence-based. Yeah, Nancy?
Are any of the OB providers reluctant to prescribe antidepressants?
They were in the beginning. I don't actually experience that much anymore. They're pretty willing because they can call us, and usually if they're reluctant, if we offer to do a face-to-face, they're usually willing. So they may say, oh, I don't do this. And we'll say, well, we could see the patient for a one-time consult and, do an evaluation and give you recommendations. Say, okay, I'll do it then. And then the next time they call, they've already had the consult and they've done it once, so they kind of don't need that face-to-face again. So yeah, we find that there was much more resistance to that in the beginning, but the more we've done it, we've really see actually very little resistance to that now. But that's been a culture shift. Yeah. Oh, yeah.
And you see, the converse of that, is there concern about cold being treated like you talked
Oh
about
yeah,
yesterday, that-
huge.
And so is the check for that when you have the consultation on the phone, so you make sure they assess that the patient's actually depressed and doesn't just have an elevated score?
Yeah, so we do, we worry about that a lot. So that's actually like the next grant we're applying for. We're trying to think about that assessment piece, because I talked about how, and if you go to that depression care pathway, that Mcpatcher for moms kind of focuses on detection, assessment, treatment. But I actually think a lot of times what's happening, people are jumping from detection to treatment, and that assessment step is getting missed. We do worry about that for two reasons. One, are they really assessing them? Do they really need treatment? And two, we worry about them missing bipolar disorder. So we're kind of now thinking about how can we make sure that assessment step is happening, but in a way that's palatable for them. So on the phone, yes, we do ask about that for sure. And that allows for that. The problem is they don't call us all the time, because once they become comfortable, treating, unless they have a question or they need care coordination or there's something more complicated, they may not call us. Because a lot of times if they have 3 or 4 phone calls with us and they've heard the same kind of spiel about how to titrate an SSRI and the risk and benefits, they're like, oh, I got this. And then they're just doing it. So we don't have that opportunity. So that's one of the things that we do worry about that. Yep.
Did any of the patients have a history of depression prior to becoming pregnant?
I just realized I'm not repeating the question, so people outside can't hear them. So the question was, do any of the patients,
Either diagnosed or undiagnosed depression prior to becoming pregnant?
yeah, that's a great question. So do any of the patients have a history of depression prior to becoming pregnant? Yes. So we actually, I didn't mention this, but we also do preconception consults because ideally, I mean, you know, unfortunately, a lot of pregnancies are unplanned, so we lose that opportunity. But ideally, this actually happens before the patient's even pregnant. That, you know, as someone who has and a third of people that have postpartum depression enter pregnancy depressed. They already have it. And a third of people develop it during pregnancy, and about a third develop depression postpartum. So we got to start before the postpartum period. And so what ideally we encourage providers to do this is call us preconception before they've even done this and have a conversation about it before the patient's pregnant. And ideally they can get them, you know, stable and in a good place with therapy and whatever medication they need, or simplify their meds if that's necessary before actually they become pregnant. Yeah, it's a good question. Yep. Yep. So that comes from, the question was, where did this number come from, the cost? So it was a study done in somewhere in the Midwest. They did a study and they looked at this, and that was how they came up with this 22,000. I believe they looked at it included societal costs like missed days of work, it included healthcare utilization, and it included a lot. It was pretty broad, so it didn't just include ER visits. It also included days lost to work and such things. That's where they came up with those numbers. Yeah, yep.
You mentioned there being trouble tracking things over time, or
Yep.
things are difficult. Did you find any way to improve a system or sort of prompting when a follow-up was needed?
Yeah, it's a good question. So the question is, I had mentioned follow-up tracking over time, and did we find a system true to prompting? So what we're doing, in which we just beta tested this, is we're using this application called Quickbase. It's a web-based application, which is actually a lot of times used for research. So it's very HIPAA compliant, and we're using this actually with all the practices because we couldn't get into the 6 practices EMR. I mean, that's like a project in itself. That would just be, I'm sure any of you who work with EMR would make all your heads spin. Like, that's not gonna, we could never do that. So we decided to create something on our own. And what that has is it has a system where the navigator answers the score into this program, and it prompts them. Like every time it's their time to be able to check the score, it'll prompt them when to call back. It'll also show them whether the NBQ is positive. So if they're on a post SSRI and their NBQ is positive, it'll be there. And they could tell the provider, hey, I don't know if you saw this, their NBQ is positive, you just started Zoloft. So we're using that system to be able to do that. And we did it with the beta testing, and it's actually pretty easy to use. We find it work. The tricky part is it won't be integrated to the EMR. So it's a little clunky. It's the best we could do with the study. Ideally, you'd have that actually in an EMR. In this, so when the navigator in each practice is pretty different because first we thought always has to be an MA, but then we found that some practices would say we don't have an MA, we only have RNs, or we want it to be our social worker. So going back to the one size fits none, we're very flexible around that. So in some practices it's going to be an MA, in others it's going to be a social worker, in others it's going to be an RN. So it'll really depend. And then when we did the beta testing, it was an MA. And she was really able to do it. I mean, she was very committed to it, and it was definitely doable for her. Yeah. So I think we're out of time. So I'm going to be here certainly. So thank you for your attention, and I'm certainly around.